So the SimMan has some features, that is, you can see some breathing movements, respiration. Okay, so you'll be able to see some breathing movements,
Yes.
right? And then you can see that eye opening can be there. All right.
Okay,
the
sir.
patient cannot verbalize, but we can give a patient voice.
Okay,
So
okay,
these
sir.
are the things which can be there.
Yes,
Can
sir.
also show some monitors. Like if you want a monitor to be attached, if you're walking into an OT, usually you would like to attach all the monitors, check the fluids and all those things.
Okay, sir.
Same thing can be done here. So we'll have our technician. He's going to be technician. So he's Mr. Shiva. He'll be the technician.
Okay,
right?
sir.
So he can help you with the monitoring part.
Okay,
So
sir.
you can have the monitors displayed. This, can we have it displayed? Yeah. So this is an old workstation.
Okay,
So
sir.
we don't have an oxygen supply as such. We
Yes.
are going to run it through cylinders.
Yes.
Okay, so the idea here is to learn about mask ventilation and intubation and decision making for the same if there is going to be any difficulty in either of these.
Okay, sir.
So if you see that, when you ask for a monitor, you will get all the displays.
Yes, sir.
The ECG and monitor.
Yes.
Usually in your OT, is it going to be a similar setup? Like
We don't have ETCO2, sir.
You don't have ETCO2, but the monitor is going to be behind you.
Yes, sir.
The workstation is also going to be behind you. This is how the normal setup is. Is that
Yes,
not?
yes, sir.
And this is what we have as the circuit. All right. We'll open the second cylinder. Okay. So this is the oxygen supply. So since we are going to use over the cylinder,
Okay, sir.
I'll prefer not using a flush. Then it will get over quickly.
Yes. Okay,
so,
sir.
This mask, this is a closed circuit, and this is a very old machine. Have you seen this? Have you used this? Yes.
Yes,
so
sir.
You can just close the APL wall
Okay, sir.
like this, and then you can mask ventilate. You want to try mask ventilating?
Yes, sir.
It's going to be a little difficult, but you can try. Just try it once. You can take the bag there.
2% will check.
Yeah. Okay. So if you see, okay, I think it is little difficult for you to ventilate. As he said, can you try a 2%? Yeah.
Yes.
Yeah.
Yes, sir.
Okay, so if you see, if you hold it, even if there is a leak and the bag is not filling, if the chest is rising and the EtCO2 is coming, that means it is getting ventilated. Okay, so this is because the SimMan has some problem with its structure. It's not like pliable like us. So there is some leak. Okay, so
Okay,
a
sir.
good ventilation means the chest rise will be there and you will get EtCO2, even if the bag is not filling properly. Is that okay?
Yes, sir.
Is that okay?
Okay,
Right.
sir.
Good. And then you have an airway trolley here.
Okay, sir.
Okay, so you have an airway trolley. You want to have a look what is there in the airway trolley?
Yes, sir.
Yeah,
I will
go
look
and,
at.
go and have a look what is there in the airway trolley. Something very similar to what we normally have. Okay, so usually these are the things which are normally available in the OT.
Yes, sir.
Right. Okay. So, all right.
Yes, sir.
Airways are available. Nasopharyngeal is there. Laryngoscope, endotracheal tube.
Okay,
And
sir.
As I said, Mr. Shiva is the OT technician.
Okay, sir.
Okay. So this is going to be. I'll just give you the scenario.
Okay, sir.
So you can actually intubate the patient. That is SimMan, right?
Yes, sir.
The patient has to be treated with absolute respect. Like, though it's a mannequin, you have to imagine that this is an actual patient. So you can talk to the patient,
Okay, sir.
right? So the voiceover might be given by us. So usually, like how you start off an induction, you can start off the induction. The time and all might be shortened.
Okay.
Usually we give a vecuronium, wait 3 minutes. That might be shortened. He might tell you the little bit of a time interval. So we'll be giving you some hints to move ahead with the scenario.
Okay, sir.
Alright?
Yes, sir.
So I want you to actually get involved in the scenario as much as possible. Think of it as a real patient
Yes,
and
sir.
a real scenario in your OT.
Okay, sir.
Only then
Yes,
you
sir.
can learn the maximum of it. Right?
Yes,
so
sir.
I'll give you the scenario. Okay, so he's Mr. Raja,
Okay, sir.
24-year-old, coming with 2 days history of right iliac fossa pain. Okay, so he has been diagnosed with acute appendicitis and is planned for a emergency laparoscopic appendicectomy.
Okay,
Right?
sir.
And he has a history of snoring, but otherwise no history suggestive of a obstructive sleep apnea. He's
Okay,
already
sir.
been assessed by a consultant. That's the case sheet.
Okay, sir.
All right. So he has been assessed, but since he had to go somewhere, you have come here. All right. So as with actually your original roles, he is the student here, and he has accompanied a senior consultant to one of the operating rooms.
Okay, sir.
All right.
Yes, sir.
This is good. Okay. So can you just say back what I tell me back what I have said so that I know that you have understood what I did.
Okay. So, do you want me to repeat the history,
Yeah,
sir?
like the patient details.
Patient details. The 24 years old male, Mr. Raja, had come presented with the complaints of pain over the right iliac fossa, and he was diagnosed as acute appendicitis, and he is planned for laparoscopic appendicectomy.
Okay, good.
He is posted for
Emergency laparoscopy.
emergency laparoscopic appendicectomy.
So we
That's
have,
history of snoring.
He has a history of snoring.
but no obstructive sleep. Very good.
Okay, sir.
Okay. So we have propofol and drugs available.
Okay,
so,
sir.
The technician will be just giving it, like it will be just showed, but won't be given as such.
Okay,
But
sir.
we'll assume that the drugs are
Given. Okay,
so
sir.
some of the things will be presumed, some of the things won't be presumed. Like mask ventilation, even if the bag is not filling, the cap flow has to come. So those things will not be presumed.
Okay, sir.
Ventilation has to have all these things. Laryngoscopy won't be presumed. You can actually do a laryngoscopy and then do the intubation. Right? The intubation, you should get the capno and all the hemodynamic changes, tachycardia, managing the depth of anesthesia, all these things will be there. No vaporizers are available.
Okay,
We'll
sir.
assume that they are available.
Okay,
Now,
sir.
one major difference in simulation is you have to vocalize what you are saying.
Okay, sir.
Okay, you have to what we think you have to say aloud so that people who are listening to you, they understand what you are saying. So
Okay.
that is one additional thing which you have to do, which you usually don't do in the operating room, is it not?
Yes, sir.
So you can say that I am going to pre-oxygenate the patient.
Okay, sir.
So that people follow what you are saying. All right?
Okay, sir. Yes, sir.
All right. So we have Dr. Gautam. He'll be the surgeon. He's a senior surgeon here. He has come for the lap appendicectomy. We have Mr. Pugat here. He's the male nurse. He's the staff nurse here. All right.
Okay, sir.
So these are going to be the people here.
Okay, sir.
So you're all good to take over the patient.
Yes, sir.
All right. Okay. So you can see some cameras around. Like I hope you can just skip those things.
Yes, sir.
Okay. So the patient is all yours. Okay.
Yes, sir.
Okay, is the patient is ASA1 or ASA2? Like
Sir, he comes under ASA 1, sir.
he doesn't have any comorbidity.
No comorbidities, sir.
Okay. Does he have any anticipated difficulty airway?
No, sir. No, sir. No anticipated. He comes under Malambati 1, sir. Class 1.
All right. What is his last meal? Is he being emergency? We leave it be
Sir.
emergency.
Okay, sir.
Probably we assume that we will give a Rantac and Perinam for this patient.
Yes, sir.
And that concerns in this patient is they are going for emergency. Any emergency procedure is high risk procedure. There is high risk of aspiration in this patient.
Okay, sir.
Second thing, patient is posted for appendicitis. That means the patient probably in sepsis.
Okay, sir.
In that case, the oxygen demand will be high.
Okay,
So
yes, sir.
we have to adequately pre-oxygenate the patient. The patient will
Okay,
be
sir.
hyperdynamic circulation.
Okay,
And
sir.
of course, we have to give antibiotics.
Yes, sir.
All right. Now, sir, do you have any concerns to say to us?
I want things to be done fast. I have another case to go out.
Fine, sir.
Haven't you intubated the patient yet?
Yeah, I will do this.
Okay.
Yes, sir.
Remove the drapes. I have to put that.
It's just we didn't induce, sir. Just give
Sir.
me 5 minutes.
No,
I will do it.
I don't have time. I'm just going to clean and drape. You
Sir.
please go and intubate. Please pull out the drape.
I'll pre-oxygenate,
Just
sir.
keep-
I'll have the
Did the consent, have you
Mask,
given
sir.
consent for anesthesia?
Yes, sir.
Anesthesia consent was
Yes, sir.
obtained?
Anesthesia consent has been obtained, sir.
Okay, IV line was taken?
Yes, sir.
IV line was taken?
Yes, sir.
Okay, so we will give,
Pre-oxygenations.
okay, what is the baseline vitals? Show me the baseline vitals. What is his saturation, what is heart rate?
So, it's pulse is 84 per minute. It's
What is his weight of the patient?
weight
Because
is
he has a
84 kg, sir. Yes, sir. Yes.
So
84
he is,
kgs.
obese for his age.
Yes, sir.
So in that case, we have to take that consent is also that consent of obesity in inducing a general anesthesia patient.
Yes, sir.
Okay, this is his baseline vitals.
Okay, sir.
So now we will start inducing
Pre-oxygenation.
the patient.
Okay, sir.
Sir, Raja sir, மூச்சு நல்லா மூச்சு விடணும், ஆழமாக மூச்சு எடுக்கணும், பயப்படாதீங்க. மாஸ்க் வைக்கிறப்போ பயப்படாதீங்க, இதில் பிராணவாயு வருது, சரியா?
Okay, sir.
Please make it faster.
Yeah, I will.
I am pre-oxygenating,
You
sir.
are pre-oxygenate the patient.
Yes, sir.
I mean, ask him to. I will give a fentanyl. I will give propofol.
Okay, sir.
Fentanyl 2 mg per kg per minute.
Yes, sir.
And propofol we will give a 2 milligram per kg.
Okay, sir.
Total body weight 2 milligram per kg. So fentanyl given, propofol
Okay,
given.
sir.
Okay. Now, are you able to?
So eyelash reflex.
You lose the eyelash reflex. No?
Yes, sir.
The patient is sedated.
Now the eyelash reflex is gone, sir.
Whether you are able to ventilate the patient or not.
Okay, sir.
Okay, Shiva, come here. Please check the cord ring.
Yes, sir.
Can't waste time.
Able to ventilate the patient? I am
Yes,
going
sir.
to give
Yes, sir. Able to ventilate, sir.
Metronium 0.1 mg per kg.
Okay, sir.
Metronium is given.
Yes, sir.
Please keep the suction connected.
Okay. Vitals are stable. Saturation is okay.
Okay, sir.
Metronium given, you can 3 minutes over.
Yes, sir.
You are given 3 minutes of pre-oxygenation with normal tidal volume ventilation.
Okay, sir.
So now you will intubate the patient.
Okay, sir. Get the laryngoscope.
The laryngoscopy and give 8.5 size tube. Have you positioned the patient properly? Right. Okay. The patient is not properly positioned. Right.
I don't know why you guys are taking so long
Sir.
to intubate. Please make it faster.
Yes. Can you intubate?
Sir.
Can you please take over? I can't waste any more time.
Yes, sir. Just a minute. The saturation is fine. So give me just 5 more minutes. The things will settle.
Actually,
So you cannot intubate.
yes, sir.
All right.
Can't intubate, sir.
Okay. Sir, there is a difficult airway is anticipated, sir. There is a difficult airway going on. Please give us 5 minutes.
Why
We will
can't you
settle
keep
down.
things ready before? And I told you I have to go early.
Yes, sir. Please cooperate with us, sir. Sorry for the inconvenience. Okay. So you are taking. Are you able to? Okay. Now you are.
Sir, no, sir.
No.
Not
just
able
take
to.
out the scope. Just mask ventilate again.
Okay, sir.
Take out the scope. So now we will optimize the positioning. See, the patient is not positioned properly.
Okay, sir.
You are not given the proper neck flexion.
Okay,
so give
sir.
Neck flexion. Is there?
Neck flexions.
No. See, the patient is desaturating because we are not ventilating the patient. Okay. You able to ventilate the patient or not?
Yes, sir.
Able to ventilate the patient.
Yes, sir.
Right.
Able to ventilate,
So,
sir.
first you have tried.
Okay, sir.
Positioning, we assume that we had keep a proper positioning like neck flexion.
Okay, sir.
Still we are able to ventilate, no?
Yes,
but
sir.
Still the patient, we are. What about ETCO2? Is ETCO2 is available? So that we will check the adequacy of ventilation with ETCO2. May I get ETCO2?
Oh, it's not coming, doctor.
ETCO,
No, sir.
then we are, okay, then,
Desaturating. Do something faster.
okay. So what I will do is, I will have one try.
Okay,
I will
sir.
see what is going on with the airway. So,
Okay, sir.
is there, what is the CL grading? Can you able to
Sir,
say any CL grading?
Cormac Lehan grading, it's 3A, sir.
3. Okay.
Okay, sir.
So, give me another.
4 size blade. We have a 4 size blade.
So, what is the previous grade you have used?
Sir, I used size 3, sir. Shall I give pressure, sir?
Yeah, I cannot see anything.
Okay, sir.
Why don't you call somebody for help?
Yes.
How long are you going to keep doing this?
No, sir. Just we will maintain oxygenation now. So it is. Am I able to please ventilate the patient? Just.
Okay, sir.
Please ventilate the patient.
Okay, sir.
So we are not able to see the epiglottis.
Okay, sir.
So it is CL grade 3B to CL grade 4. Now we are unable to intubate the patient.
Okay, sir.
So what we will do is at present we have to, anyway the saturation is maintaining, but ETCO2 is not coming. So what we will do is we will put a supraglottic airway device.
Okay, sir.
At present we will try supraglottic airway.
Okay.
Supraglottic airway device.
LMA size 4, 5.
LMA size.
Size 4 or 5, is it there?
Okay. So
Okay.
LMA போட்டுருங்க. Size 4 போட்டுருங்க. Whatever it may be, you put LMA.
So, deflate that. Okay. Get a gel.
No issues, no issues.
Okay. Okay. Right.
Right, okay. Yeah.
It's not going in.
So the ETCO2 came. We assume that we have inserted the LMA.
Okay, sir.
ETCO2 arrived.
Thank you, thank you.
Okay, sir.
Thanks a lot.
Now we have done a mistake. What we have done is we have to follow modified RAAMED sequence because the patient status NQ is not known.
Okay, no problem. Yeah.
Thank you. Thank you. Thank you.
Thank you, sir. Thank you, sir.
Surgeon was asking us as he had a neck surgery.
Okay. So you felt it's something which we all go through, whether we are in the ER or intensive care. There's always another person who has other priorities than what we do. Okay, so that's always there. So and it's nice that you could feel it was realistic. Do you think you would do something very similar in your operating room if you come across such a scenario? I'm not talking about the outcomes, but the decisions which you make and all those things. Is it very similar to what you normally do in the operating room? You are, I think, new to the field, but is it something which you see normally being done in the operating room?
Yes.
Very good. So now, if I may ask you, like we go through the debrief through few steps. Okay, that is first. You can tell me what you felt happened. Okay, then we'll ask the other people who have seen it. Okay, if they have observed anything more, or there are certain things which you might have observed which they might not have observed. Then we go into something called as the description of why we did those things, and then we come to the conclusion. So this is how we are going through the debrief scenario. Okay. So can you walk me through what happened from the moment you have handed over the case? What all happened from your point of view?
The patient was posted for a endoscopy appendix interview.
I know it's late in the day, but
We started
yeah.
with the pre-oxygenation.
Okay.
We started with pre-oxygenation.
Okay.
We gave pre-oxygenation for around 3 minutes.
Mm-hmm.
And we have used with the 3 medications,
Mhm.
with the anti-cytokines and anxiolytics, and we have injection agents. We are given propofol.
Very good.
This is up to mg per kg. And we try to indicate the size, the age size of the identification. But the patient who had a difficult intubation, we were not able to visualize the vocal parts. And the Cardiac Anesthesia classification, it was class 3A. Then we tried for a supraglottic airway devices.
Okay.
And we have taken a supraglottic airway device of size 4, and we try to insert.
You could achieve the ventilation, right? So, from your point of view, can you add on something other than what was?
Yes, sir. First of all, what I the wrong thing is the patient is 84 kg patient in this 24 years.
I'm very sorry to interrupt you. Like we'll definitely come back to the the issues which we had. Can you just describe the way the scenario went so that we all we just want to confirm whether we all saw the same thing before we discuss the scenario. So can you add on anything else which what did you do first? You did something really good when you walked in. With the patient and the surgeon. Is it not? He did something really interesting when he came in.
First of all, before keeping the mask, we have to relieve the apprehension of the patient.
Very good.
Once you keep the mask, the patient will be apprehensive. And second thing, what the surgeon expects from us, or any particular concern the surgeon may have, that we have to take that into account. Otherwise, this patient is able to ventilate but unable to intubate. Simple.
Okay.
That's what I perceive.
Okay. Anything which you can add on, which you had observed during the steps, which other than what he had seen? He has explained a few things. So there are so many other things which were happening during the steps. So can you pick up few of the things which had happened during that scenario? Like his interruption or some other things. Yes. Anything else which you had observed from your point of view? He has given a good idea of what has happened. Now may I go to others? Probably, I think we have spread out a little bit towards the back, but may I start from the back, right? Did you observe anything else from your point of view? What has happened during the scenario? Because we all want to be in the same part, discussing the same thing, right? Okay. So we might also have the scenario coming up in some time, right? Yeah.
What they could have done.
No, what has happened? What happened? Other than what he has said, did anyone in that last row observe anything different?
So they would have put a stillet and try to intubate.
Okay, those are solutions. What I want to know is regarding the scenario as such. Could any of you observe anything else?
It's an emergency, sir, but I don't know whether we can go for rapid sequence injection and intubation.
Okay, so again we are thinking of the possibilities which they could have done. So one of the things which I had observed in the part is before he started, anesthetizing, he looked for the consent and he looked for the IV access. So those are all important factors. How many of you have had a scenario where you have started the case and then you find that the IV is not working? Anyone? Anyone? Yes. So you do have large number of people. So these are things which we feel are not significant, but it was very important that you did it. Like you looked for the consent. Okay, we have had scenarios where even consent has not been taken, but I think it might not be good on camera to say. So IV might be a lesser evil. So the IV checking and IV line. So the thing is, when we walk into a real life scenario, there are things which we take for granted. Okay, like a working IV. So there are things which we assume is working, but it's always good that you recheck. Okay, it can happen in the ICUs and the ERs as well. Okay, so where you assume that something has been given and then you end up having an edematous limb. I think all of you must have come across it. Like at the end you have an edematous limb, right? So what he did right, what I saw, what I could see from that was he looked for the consent, he talked to the surgeon. Okay, so they are all very important. So maybe he got a little angry a little later than earlier, probably because he talked to the surgeon. And then he was a very good communicator because he read back the whole thing on the history to make sure he could understand. Though it was a junior person in front of you, okay, as a leader, as a team leader, I find that he read back the whole thing, right? And then he communicated to the patient, okay, and then he said what drug was given. Okay, so anything now that you can add, now that I have said all these things, anything else which you can say?
It's a difficult situation.
Very good. So he declared the difficult situation at the right time. Okay, now can we come to the attempts which was done? So all these were really good things which can sometimes get masked because of the anxious part which we have done. So when you finish a case, since this is the first time you're all attending a simulation session, I'm a little going off track. Okay, so when you go through a scenario and you have a difficult scenario, okay, at the end of the day you have a pulmonary embolism or you have a massive hemorrhage, patient goes to the ICU. When we say somebody has to sit and reflect or the team has to sit and reflect, it's not just what went wrong. Okay, what we have to first decide is what all happened, whether it is right, wrong, neutral, doesn't matter. You write down what all happened. That is called as a reflection. What you saw as a team leader might be different from what your junior person must have seen from this point of view, what a surgeon must have seen from this point of view, what a nursing staff must have seen from his or her point of view. Okay, so you write down what all happened and then you can elaborate on it, right? Now can we go to the specific part of the sequence of intubations, like how we write a flow chart, right? So first pre-oxygenation followed by induction, mask ventilation, and then what else? Can we have a...
Yes, he is able to mask ventilate. Meanwhile, the patient desaturated. During the first attempt itself, the patient desaturated. So the first endoscopy attempt we did. So next attempt, because the obese patient, we optimized the position of the patient. We assumed that we optimized the position of the patient. We had put the ramp position. Again, we mask ventilated. Then the saturation picked up, but probably ETCOD did not come up. So that means the ventilation not happening, but the saturation is still able to maintain the saturation. So second attempt, again, he had failed in the second attempt. So what we now, second attempt I had made. Second attempt I had made because he said CL grade 3.
Okay.
So after a proper positioning, optimizing the position, adequate again, achieving the reoxygenation, I myself tried the laryngoscopy. There again I find the CL grade 3B, so fully verimatous oral mucosa, and nothing is seen. So at that time I declared it is a difficult airway situation to surgeon, and I should have called for help actually. And then so now the savior is second generation, because the patient is full stomach. We don't know the inflow status. So the ideal for this patient will be second generation LMA. So we had inserted a second generation LMA. The patient, I am able to ventilate the patient. I have achieved the ETCOD.
So maybe have the video of what happened. Do we have the video? So we'll just quickly have a look. I hope I won't take too much of your time. Okay, so this time around, since it is possible, yeah, they can go a little forward. And the moment they take over. So how many minutes do you think you were inside the scenario?
10 minutes.
10 minutes. Okay. Yeah. So now I want you to closely look at each step and describe at the end of the scenario any additional step which you have seen. Right? Can you keep a close eye on what is happening?
So he comes under AC also. He doesn't have any more. Does he have any anticipated distant airway? No. That is not anticipated airway. He comes as what is his last doing? Because in emergency, probably we assume that we will do a RAAMED and that concerns in this way forward that going for emergency. Emergency procedure is risk procedure. There is a risk of aspiration in this case.
All right. Yeah. I think from here we
Is the concern, concern for anesthesia? Yes, sir. Anesthesia concern your submission? Yes, sir. Okay. Are you mistaken? Yes, sir. I will mistaken. Okay. So we will do okay. What is the baseline vitals? Show me the baseline vitals. What is his saturation? What is heart rate? What is his weight of the patient? Because he has a swimming 84 kg, right? So he is obese for his age. Yes, sir. So in that case, we have to take that concern also. That concern of obesity is yes, sir. Okay, this is his baseline vitals. Okay. So now we will start using the patient. So Raja sir, மூச்சு விடணும் ஆழமா மூச்சு விடணும் பயப்படாதீங்க மாஸ்க் வைக்கிறப்போ பயப்படாதீங்க இதுல பிராணவாயு வருது சரியா asking to I will give fentanyl, I will give propofol to fentanyl 2 mg per kg per minute.
Okay. Any inputs? Yes.
Another good thing that we did, we checked for the baseline vitals.
Very good. Yes.
For it.
Yes.
So that was
baseline part. Now, my question is with the pre-oxygenation part. Anything which you had observed with regards to the pre-oxygenation? Chest raise was there, yeah, the ETCO2 was there, yes.
In this patient, pre-oxygenation should be done with a vital capacity drugs rather than doing.
No, either 3 whole minutes or 8 vital capacity.
Okay, what all, let me, I would have liked to check a few things before I keep a mask.
No, baseline pulse, baseline saturation without
Saturation, okay, anything else? I would like to, see certain things before I keep the mask from the patient. Anything? Position of the patient, okay. Very good. He did it in the second time. He rechecked the position. Yes, that is fine. Selection of mask is good.
Scopes, everything.
Scopes is they did a check. Huh? In tidal oxygen, somewhere near. Okay, sorry. So in this case, after the second attempt, something has happened. Not sure if this is the place.
What is the CL grade? Can you able to say CL grade?
Okay, the back part is there. Okay, he's taking over the respiration, the ventilation. No, he's taking over the laryngoscopy, right? So before that, I think I'm not able to retrieve it. So what are we trying to provide to the patient? So, and in between, so actually the oxygen flows were not on. Okay, so usually we have to ensure. In fact, in between he went and you had switched on the oxygen. Did you realize that? Yes.
So I thought I will leave the mission part.
Okay, that's fine. That's fair enough. Actually, sometimes we presume that part. Actually, that is fair enough. But by my reflex probably we had went again and then switched on the oxygen. That's sometimes some things get imbibed in our part. So before we keep a mask over the patient, we have to ensure that the oxygen is on and the circuits are in the right place, and before we oxygenate the patient, right? So in fact, we didn't want to continue with that part, so we just assumed that. But you had corrected it when you took over the ventilation. So some of the parts are kind of by reflex we do it, right? Is it not so? Switching on the oxygen is a very important part, right? I know it might sound crazy, but again, if you ask me, have I done it before? Yes, I have done it. I've kept a mask before without switching on the oxygen. I've kept on a mask with an alternate circuit. All these things have been done, right? So when we are anticipating some difficult airway and when we are pre-oxygenating, I would have liked to oxygenate the patient to the fullest, but of course the end-tidal oxygen and other things were not displayed here. So once we knew that, we would have known that it was not getting oxygenated, right? So we just go back to the attempts. You did, so the sequence was pretty right. So I just wanted to re-stress on this is how we go about it. So this is the first step.
Saturation is fine. So give me just 5 more minutes.
I've always wondered how long should I try an intubation before I go back to mask ventilation. What are your thoughts on it? When should I go back to mask ventilation if I'm not able to intubate? When do you do it?
So that depends upon the hemodynamics of the patient. What saturation level is maintained.
Okay. Any other thoughts from your end?
10 seconds,
10 seconds, okay. Any thoughts from the senior people here?
Saturation.
Saturation.
If it is the patient is doesn't want his ICP to be raised or hypertensive patient, There the recommended guidelines is less than 15 seconds is the scoping time.
I totally agree with that. So 15 seconds might be a good enough time for us to decide whether we need to persist with the scoping or we need to go back to. So what do you think are the options when in the first scopy we are not able to visualize the glottis? I think we have had a long session on how to go about it, so let's put it into perspective. So this is the scenario.
The next attempt can be with either a different size blade or a different blade, like a McCoy blade or something.
Okay. That is, would you like to still persist with the scope and change the scope, and is that how we go about it? It's like, I would have liked to probably go back to mask ventilation. Is that okay?
Because there was a drop in saturation, obviously you have to
Okay,
go
so
back.
if there is no drop in saturation, you would still like to go ahead with another.
But between the changes, I would like to ventilate.
Yeah, I think
The situation we will try to mask ventilate.
mask ventilate. Okay, so that's coming from a person. I agree with that. Maybe I will go back to mask ventilation. Why do you think we have to go back to a mask ventilation? Can you say? Because there has to be a reason why we have to go back to a mask ventilation. Maybe as she said, like she feels that in the first scopy, the 3-size blade was not reaching the varicula. So quickly change the scope probably into it. Why not?
It's already had a period of apnea, so
If there is a desaturation, could be damage. Any other cause?
he's had an episode of apnea already, so his oxygen reserves are low. So if we can mask ventilate, we can at least bring it back to a little near normal before we make another attempt.
Okay, but he said like he might wait till the desaturation. Is that fair enough?
While you're waiting to change the blade or while your technician is doing that, you maintain oxygenation by mask ventilating the patient with 100%.
All right. Okay. So what does that give you? Like, yes, it gives you a little bit more time to think about what has happened. Right? Is it not? So as you can see, like we know that certain it's not a rigid rule of what is to be done, but then there are safer options. Okay, when it comes to the patient, I prefer a safer option of going back to a mask ventilation. Okay, now if as she said, like that it's a pretty valid argument saying that I saw that the problem was with the blade not reaching the valvula. Would you now go with the second attempt or go back to a mask ventilation?
If it was a problem with the blade, I would like to change the blade and try.
You still would like to change the blade before mask ventilation. Okay, so I feel that there is still a risk if the second attempt is again going to be difficult. There is still a possibility, right? The second attempt could be difficult. Then you might end up with a falling saturation. Is it not? So
If you're going to start the second attempt with a saturation of 95%.
Because the saturation was low, obviously it has to be mask ventilation cell. But if the saturation had been normal,
Already have
then
been
maybe.
ventilated for
okay. So can somebody maybe the person there is the person who's looking to the left. Yes. Yes, sir. Yes, sir. Can you say what is happening and what is your thought on what is going on? We'll quickly try to wind it up. Because the whole thing is on mask ventilation and laryngoscopy. What is it? You're an anesthesiologist? Huh? Technologist. Okay, fine. Would you like to just pass it on, or would you like to give a comment on it? You would like to pass it on. How about the person here, please?
I would go ahead with
The second laryngoscopy.
I would mask ventilate it will be.
Okay.
In case if the second attempt is going to be difficult, at
Okay.
least it will be a saving.
Okay. So I think that's the final consensus probably, because it's a future event. A probability, that's what she's saying. There is a probability of desaturation. Okay, so we are going to reduce that probability to nearly zero by mask ventilation. When we are not going to do it, there is still a probability, a 50% chance that there can be a mask ventilation. So in anesthesiology or in critical care, we don't take that big probabilities. Okay, even above 1% is big enough for us. Okay, so maybe I agree to the overall consensus that we go back to mask ventilation and then probably give a second intubation attempt. So this is where a translation of guidelines and flow charts and the theory classes, when we put it in perspective in a real life scenario, do we actually translate it into our real practice? Okay, so such scenarios help us in reflecting on the things. Now this reflection need not always happen on a simulation scenario. This can happen even during your daily cases. You finish a case, objectively, you're not going to support you. Nobody is going to know whether you're going to justify yourself or not. You're going to objectively write down and see how much of it is, reflecting from the guidelines or whatever is there in the scientific literature. Some of it might not be there in the scientific literature. Okay, so but you just see whether it is a safe enough practice. Okay, then you can tick all those things. If you see that certain practices are maybe, those are modifiable factors, you can probably modify it. Alright? So, do we have time for another scenario?
So you can integrate this. So there is a difficult airway is unstable. So experiments are there. Do something faster.
So this is the last part of it. So there was no ETCO2. Mass ventilation was also difficult. So this is the scenario ends with the placement of a supraglottic airway, which is exactly what the guidelines say when you are not able to mass ventilate. Alright? So we stop here. So concluding comments from you.
So this patient ideally, what I would do is first I would put the rights to.
Okay.
Because one thing is we don't know what is the status.
I'm very sorry to interrupt actually. Take home messages quickly.
Ideally, this patient should have induced in a RSI manner rather than a reoxygenation with cardiac. So we will reoxygenate with 4 or 8 fatal capacity breaths and we will do modified RSI.
Okay.
And the rest of the steps to follow.
Alright. What is your take home message from this? Take home message from this scenario.
One more thing is obese patient with history of snoring, I will attach a nasal box if available or a frequency is available during my induction.
Since the patient is an obese patient, we should always consider a backup plan for either for a supraglottic airway devices or
So you want a backup plan, that's the final. What is your take home quickly? So we'll just finish it off with this last one. May I just modify the question? Actually, not the corrective steps which we take from the part. What will be the take home? Like if you have learned something from this, what have you learned from
We
this?
need to plan and prepare for every case.
Plan and prepare. Very good. Okay. All oxidation. Very good. So, and quickly, if I may ask, you are not able to mask ventilate. What can you do? What is the option? LMA. And if you are able to mask ventilate, difficult laryngoscopy. What is the next step? He has done that perfectly this time. What was it?
Optimizing position.
Very good. Optimizing position, going for alternative techniques. Okay. So this is what exactly we have learned over the day. Is it not? So all this was done in this particular case. And when you are not able to mask ventilate again, he went for a supraglottic airway. Alright. So thank you. So anyone has energy for one more scenario? I don't think so. Alright, so all good. So let's hope you are able to work on all these things. So just as Dr. Sendan was highlighting a few things, like it's not related to the skill alone. Since the learning objective of this was mask ventilation, we were focusing on more on that. So what can be highlighted in each reflection need not be the same factor. You can highlight on his team, how he behaved as a team leader. Okay, so those are all important factors. He did very well, he communicated very well to the patient, to his colleague, to the surgeon. Okay, team building is a long process. If you work with the same surgeon for a long period, you keep discussing with the person, the surgeon over a period of time, you can reduce conflict inside the operating room. Okay.
It was even engage the surgeon. Though I was questioning him, he didn't get into an argument with me. So it would have shifted your entire focus off the thing, getting into it. So he was careful to answer me, but he never engaged me in he might be angry, but at that point the priority is totally different. Not yeah.
Alright, so this.
So conduct simulation already.
No, this is the first time. So he did really well. So this is what next time hopefully you'll all be participating. You'll have longer sessions, earlier sessions where you will be little. But this is exactly the time, right? You might be going for a case after this as well. You might be as tired as you are right now. So the simulation is, you can't say that this is not something which happens. This is something which can happen, right? So thank you. Any suggestions or any feedbacks? Okay, so nice.
So now how this patient, suppose really the patient wants to undergo laparoscopy or any emergency, we have accepted the second generation. It will, with this second generation, it is possible to stand the laparoscopy. So shall we continue or what shall we do?
So that's again a wonderful question. So I would have definitely loved to discuss on this. It is possible to go ahead. Like there are cases where when the laparoscopic pressure is less than the overall pressure is less than 30 centimeters of water, it's still possible to do it. Yeah, then we need to have a discussion.
What is the surgery? How good the airway seekers? Whether you can use it only as rescue or you can proceed. And the quality of the surgeons.
And this is not a made-up scenario. This is something which has happened to one of
I
similar scenario.
I
So,
woke up the patient.
woke up the patient and went for.
The patient, talk to the surgeon, put a spinal epidural.
So if it is not an emergency, then I would prefer for a definite.
And I think appendix is not a big deal.
So I will prefer for a definite situation. So it's a personal preference and the safety of the patient. If you consider, I will prefer.
I think spinal epidural still.
I also did once. I also did once.
Either you awaken the patient, there is no patient awakening, do awake factor. If you think the surgeon refuses to do an
I had one case, operating case, the patient refused for spinal anesthesia, we tried for general anesthesia, not able to sit in the air. So mass ventilation was he put LME and he rescued him. He awakened the patient, then discussed with the patient, explained, then I put spinal anesthesia and he. So situation cannot be same for all patients. So that is a different scenario. That time you have to rescue the patient. Then we can discuss. Time is there.
Okay, so sorry for all this because the priority was, since the priority was the airway, we focused on it, right? So these are definitely possible things for you to sit and reflect on. See, it's very happy that you started thinking of that part as well. So though we ended the scenario with the supraglottic airway, this is exactly the decision-making difficulty which happened in the scenarios which were then mentioned. Okay, so there are a lot for us to discuss, but as I said, the primary objective here is on the airway and laryngoscopy. That's what we agreed upon as a learning objective, right? So as I said, let's hope we can discuss a little bit more when you participate in the future sessions. Thank you.